Hi everyone, it's Dr. Custer here. Today we're going to do a pretty short video on an introduction to quality improvement. This was the video that I had prepared for orientation this year for the first years, so it's just a brief overview. Let's get started. The goals of today's lecture, like I said, introduction to quality improvement. We'll very briefly go over the Institute of Medicine report, Crossing the Quality Chasm. We'll talk a little bit about the Institute for Healthcare Improvement, the model for improvement, PDSA cycle and what does that mean, and just a few QI tools for measurement. And then we'll do a really brief overview of research versus quality projects. So, crossing the quality chasm. So this report was actually released in 2002. The Institute of Medicine had been studying healthcare quality and patient safety over the decade. And what they found was, like we talked about in the patient safety lecture, there was quite a bit of medical error going on, preventable medical error. And then they also found that there were gaps in quality of care, what was the standard versus what people were actually receiving. So they produced these two reports. This one was Crossing the Quality Chasm. And basically, the report stated that healthcare should be 6 things in order to be quality care. Number 1, it should be safe. It should avoid injury, right? Number 2, it needs to be timely. Reducing weight, sometimes harmful delays, can really impact a patient care. Care needs to be effective and efficient. It has to be the appropriate level, and you need to avoid waste. Care needs to be equitable, which means it does not vary in quality because of personal characteristics. And then patient-centered, and this is so important. Patient-centered is you're respectful of and responsive to the individual patient preferences and needs. So then we had this baseline with this report. So what is quality improvement? And you guys know from the other lectures that I do throw out a lot of definitions. This one is the definition from the AAFP report here. Quality improvement is a systematic, formal approach to the analysis of practice performance and efforts to improve performance. A variety of approaches, or QI models, exist to help you collect and analyze data and test change. So wordy. Basically, it's a standard way to look at quality and perform quality projects. We'll go through this. Here's the definition by the AHRQ report. Quality improvement entails continuous efforts to achieve stable and predictable process results. That is, to reduce process variation and improve the outcomes of these processes, both for patients and the healthcare organization and system. Another very wordy definition, but process variation. I know a lot of residents are like, whoa, what does that mean? But if you guys think about it, a process is just a set of steps in order to achieve a means, right, to the end. So variation just means that it's not done in a standard way, that perhaps steps are done by a personal preference or, by a not correctly set up process. So we don't want process variation. We want decreased process variation to improve the outcomes. So here's another very simple explanation of what quality improvement is. Simply identifying a problem and testing solutions until you find one that works to correct the problem. And that's just simple. That makes sense. In your ambulatory sites and in your hospital rotations, you will all observe gaps in care where you could think, wow, if we could just change something, that would actually improve patient care. Okay, those are the things that we're talking about. That's what we want to address when we talk about quality improvement. And it's so important for you to learn this as a resident so that when you are an attending and you have your own practice or you're part of a practice, you can identify gaps in care and know how to appropriately deal with that. And yes, you cannot just randomly test solutions. You need to have a structured model, just like you do for all math, right? All right, so here we go, the science of improvement from the Institute of Healthcare Improvement. I believe there's lots of definitions on this, and I apologize. All right. The science of improvement, it does emphasize innovation, rapid cycle testing in the field, and to see how that produces improvement. We'll talk about that. It's characterized by a combination of expert subject knowledge with improvement methods and tools. It's multidisciplinary, that's for sure, and we'll talk about that throughout your residency. And then the Institute for Healthcare Improvement released the Model for Improvement. That's what we're going to study in residency, and that's pretty much the standard for healthcare. So in other industries, you'll hear of other models for improvement, which are like Six Sigma or Lean. Those are, for manufacturing, not necessarily, can be used for health, but we're going to use the IHI model. So here's the model. So it's 3 questions in a cycle. It's pretty easy. If you think about it. The first question is, what are we trying to accomplish? So you ask this to establish your aim. So where's the gap? Let's identify it. How could, what do we want it to be? How will we know a change is an improvement? That's the second question. And you ask this to establish your measures. And then what change can we make that will result in improvement? And then you ask this to determine the change you will test. Okay, so let's just do a really quick example of something that you're very commonly going to see, if you're not a pediatric resident, and that's a diabetic patient in the clinic, right? So let's say you run a report and you're realizing only 50% of your patients with diabetes are having their foot checks routinely checked at their visits as recommended by the guidelines. Your aim or your target is probably like 100%. Obviously, you want all your patients with diabetes to have their standard of care. But you need to think of a smaller test of change, usually. So for your first aim, you could say you plan to increase the number of diabetic patients who receive a regular foot exam to 80% by, whatever time period, 6 months or 3 months. In order to know if your target aim is being reached, you need a measure. So your measure could be just pulling a weekly report on patients with diabetes and then measuring the ratio that get their foot exam if they were due for it. So that would be a way to measure the progress of the improvement. But then you have to figure out what change can you make to reach that target goal. So this is where you get creative, perhaps. There's the infamous signs, please take off your socks if you're a diabetic, that go up in the exam room. That is a pretty good way to ensure that you're compliant with that it's not forgotten as part of the visit. You could also, hold staff meetings and do like training, educate staff on the importance of doing that, give them different information about complications of diabetes. That's a really good way to help increase or improve care, is to do education and training sessions. The point is, these are small, testable changes that you can do in your ambulatory site to improve the care of your diabetic patients. And really, if everyone on the healthcare team was continuously looking for gaps in care and ways to improve these, this would just ultimately lead to so much of a healthier system. And so, let's talk a little bit about the PDSA cycle. So PDSA is just plan, do, study, act. It was founded by Walter Shewart, and it gives us a way to quickly test changes on small scale, like we talked about, observe what happens, tweak the changes as necessary, and then test again. So it enables rapid testing and learning. So really, it's pretty self-explanatory, but planning, and we'll go through this in so much more detail, but planning is setting up your target, your aim, you're picking your measures and thinking about how you're actually going to implement this improvement process. Doing is actually obviously doing the process change, and studying is looking at the results. Acting, if the results reach your target aim and the process is working well, then you can implement it. But if it hasn't quite reached the target goal, you would go back and plan a second PDSA cycle, basically. And I didn't mean a second aim, I meant a second PDSA cycle. All right, let's move on. So QI tools for measurement. It's important that you guys understand these. There's 3 that we're going to talk about today. The first is flow diagram. Flow diagram are used to understand processes. So if you have an adverse event, or if you're just trying to figure out if your process is efficient, you can put it into a flow diagram and look at each step. And we'll go through an example. The second one is run charts. Run charts are very important in quality improvement. They're used to measure effectiveness of change over time. And then the fishbone diagram, the Ishikawa, which is the cause and effect diagram, we use that typically when there's an adverse event to do a root cause analysis to see what was the root cause of the adverse event. And again, we'll talk about that a lot. So here's an example of a flow diagram. This is just a diagram of what should happen when a patient comes in with acute symptoms. Now, if you have an adverse event, it's important to do your flow diagram of what actually happened. This is what's supposed to happen, right? This is the plan. Now, if you process or you map out what actually happened, you can see where the deviation from the normal occurred. Here's an example of a run chart. You'll see that these are weekly over time. This is the average number of minutes in the emergency department. So here's our minutes. You can see they set the target aim here. It's called the goal. This is 30 minutes. So their goal was to decrease the average waiting time to 30 minutes or less within however many months. Looks like we have a few months here to look at. So here they were measuring it and they said, obviously we're not meeting our goals, so they tried something. This is their first PDSA cycle. They tried huddles. And it looks like the huddles worked, but over time, maybe there was staffing issues, perhaps, it didn't work out. So they implemented a second one. That didn't really make a change, and then they implemented a third. And the lab changes in this particular case, they weren't getting stat labs at all, and they were able to change it where they were able to get stat labs, and that really changed the protocol a lot. So this is an example of a run chart showing the trends over time. You can see where your goal is and if you've reached it or not. And we'll talk a lot more about the details of the run chart because it's important to understand that. And here's an example of the Ishikawa diagram. So your adverse event goes here. And then in this example, it's poor hand hygiene compliance. And then usually the bones of the fish are these common categories. So usually it's something like materials, methods, environment, equipment, and people. So you have to consider each category separately because there could be contributing factors in all different sorts of categories. So for example, under materials, if you were out of hand sanitizer, then that's a problem. If you're not doing the proper hand washing technique, that could be a problem. Reminder signs, dispensers, knowledge, these are all things that contribute to poor hand hygiene compliance. So that's that. So let's do a quick review. Quality improvement is the science of planning, testing, and making changes in systems to improve the care of patients. Remember the 6 Institute of Medicine: safe, timely, effective, efficient, equitable, and patient-centered. The model for improvement and the PDSA cycle are structured ways to carry out a QI project. And remember, the IHI model for improvement is simply 3 questions in a cycle. And remember the QI tools because we're going to come back to them and you'll have to know them. And they're useful. One last thing we're going to go over. The difference between research projects and quality improvement, or research and quality. A lot of times residents come to me and they say, oh, I have a QI idea and it's really research, or vice versa. So let's just quickly go through this. So the purpose of research to discover new knowledge. You have a hypothesis you're going to control and you're going to test for it and you're going to see if there's new knowledge gained. Quality improvement is different. It's taking knowledge and applying it consistently to clinical practice. So you're tweaking what already exists. You're not discovering new knowledge. In research, the gold standard, of course, is a large blinded test. We know that. But quality improvement are small, many unblinded, observable sequential tests or observations, small tests of change. Research, you don't want any bias, you control for it. Quality improvement, you recognize it and you stabilize for change to a preferred known bias. Data, you're gathering as much as you can in research. QI, you're gathering just enough to recognize if your change is effective or not, and then you will tweak it. Duration, research obviously can take up to years and years. Quality improvement are short, predictable periods. The PDSA cycles are usually at the most, 3 to 6 months, but you might start looking at it after just a few weeks. So not a long time like research necessarily. So in research, you design a study to find unknown results, and the focus is on the methods that are rigidly adhered to, right? In quality improvement, you design a study to obtain predetermined results, whatever your aim is, and the focus is on the results actually, and you continually change your materials and methods as you get them to improve. All right, that's it for today. You guys know this is my email and phone number. If you guys would like to get a hold of me, I prefer email, but I'm always available by text. All right, hope you guys have a great day.